Biologic therapies are very effective treatments for psoriasis. However, because of how they work, patients and clinicians are concerned about the risk of serious infections associated with biologic treatments. However, randomized controlled trials are not powered to look at rare adverse events, and they have a poor external validity. And therefore, we set out to determine whether etanercept, adalimumab, or ustekinumab were associated with a higher risk of serious infection as compared to non-biologic systemic therapies. We used the British Association of Dermatologists Biologic Interventions Register, or BADBIR. This is a large national prospective safety registry established in 2007 with the primary aim to investigate the safety of biologic therapies in psoriasis. And the structure of the registry compares a cohort of patients on biologic therapies against a cohort of patients on non-biologic systemic therapies. But crucially, the entry criteria in terms of disease severity is the same, so PASI above or equal to 10 and a DLQI above 10. We defined our outcome of serious infection as those infections associated with hospitalization, IV antimicrobial therapy, or death. We identified some potential confounders a priori. This included demographic factors, lifestyle factors and comorbidities, and also disease severity and treatments. We calculated crude incidence rates for each biologic and a non-biologic cohort. We then adjusted for those covariates and potential confounding using propensity score methods and inverse probability treatment weighting. We then also looked at how well our adjustment worked, so in other words, the balance between our cohorts after adjustment. We then calculated Cox proportional hazards models for hazard ratios to the first serious infection. Moving on to our results. We had over 9,000 patients in total, with our largest biologic cohort of adalimumab over 3,000 patients. Our median follow-up duration was around 1.5 years for the non-biologic cohort and around 2 years for the biologic cohorts. Table 1 shows the crude incidence rates. You can see on the right-hand column, we show the incidence rates per 1,000 person years, and they are very similar between the cohorts. Figure 2 is a forest plot. It shows the reduction in expected bias we were able to achieve, and this is an example using adalimumab. The light purple dots are the values before adjustment, and the dark purple dots are after adjustment. And the closer the dots are to the line, the less bias there is. And you can see that we were able to achieve a nice reduction of the bias after adjustment. Table 2 shows our main results. Both the crude hazard ratios and the adjusted hazard ratios in our comparison of etanercept, adalimumab, and ustekinumab with the non-biologic systemic therapies were all non-significant. So our crude incidence rates of serious infections for etanercept and adalimumab were very similar to the reported figures, but for ustekinumab they were higher. Our adjusted results are very similar to SONAT. This is a European collaboration of psoriasis registries. They had compared a cohort on TNF inhibitors against a cohort on acitretin and methotrexate and cyclosporin, and they didn't find an increased risk. However, our results are very different from SOLAR. This is a single company-sponsored US-based psoriasis registry, and they showed a higher risk with adalimumab compared with acitretin and/or phototherapy. The strengths of this study is that we used real-world data, we had a large sample, and we had detailed data capture, allowing us to adjust for confounders. We involved many centres in the UK, resulting in a high external validity, and we were fully independent of industry for our analysis. However, this is an observational study, and therefore there is the risk of residual confounding. So in conclusion, we found that etanercept, adalimumab and ustekinumab were not associated with a higher risk of serious infection as compared to non-biologic systemic therapies in patients with psoriasis. So what does this mean for patients and clinicians? Well, the risk of serious infections shouldn't be the discriminator when a patient is deciding on embarking on a certain biologic therapy. On the flip side, healthcare professionals should be equally vigilant for serious infections when looking after patients with psoriasis on any of the systemic therapies.